Hello, everyone. I'm Maria Theodoulou. I am the program director for breast cancer medicine at New York Oncology Hematology up in the Capital District. I am pleased to invite you uh, to listen to Dr. Lynn Choi and myself discuss breast surgery, and I will be learning as much as all of you out in the audience. This is one of many programs that are being funded by Stacy and Richard Rosenthal, a patient of mine from 23 years ago with high risk breast cancer when I was at Memorial Sloan Kettering Cancer Center, and who has, without question, generously and lovingly donated an annual grant for these educational programs. So I'm really excited about this. I'd like to invite you to meet Dr. Lynn Choi, who is a breast surgeon up at Albany Medical Center. She is really at the forefront and spearheading the breast cancer program there, which is going to benefit everyone up in the Capital District. Has several surgeons working with her who are also really designating their practice clearly to breast cancer. And Lynn, hello and good morning.
Hi. Hi, thanks so much for having me,
Oh,
Maria.
it's my pleasure. Can you tell us a little bit about your program at Albany Medical Center?
I'm the breast center director at Albany Medical Center. We just got reaccreditation for the NAPBC, and the most important thing about our place is it's a very multidisciplinary focused center. Dr. Theodoulou is at the forefront of my cell phone if I need anything. We talk about patients, same with the radiation oncologist,
I pay
plastic
her a quarter
surgeons.
for that.
So it's really the best thing we can do for patients is have the best team who have the best interest for the patients, always talking, making sure, are we following the latest guidelines? Are we doing the best that we can do for all our patients?
So, really, what you're saying, Lynn, is keeping yourself and your team educated so you can educate
Absolutely.
patients and
Yes.
educate all of the ancillary caretakers that are going to be really managing the patient's care. I think what I hear so often in my clinic when a patient comes to see me is, I've seen Dr. Choi. She was so lovely. She was so patient. She pays me a quarter too.
Yeah.
And she recommended that I have XYZ for the breast cancer that was identified in me. But my neighbor got a completely different recommendation. And my sister in law finally came out of the closet and she had a completely different recommendation than the two of us. Lynn, why all these different recommendations?
So breast cancer is being treated in the best way possible. So if the same patient came to me 20 years ago, you're offered this huge surgery. 10 years ago, a little less, and now we're trying to do less, but research and data shows that you still get even the same outcomes or maybe even better. So I think it is very important for patients to say, is this the right surgery? Why am I not getting this? Should I get this? It's supported by the SSO, the Choosing Wisely guidelines, which covers a breadth of cancers to be like, do I need this extra additional surgery in my armpit? My neighbor got an axillary dissection. Why don't I need an axillary dissection? But the future of breast cancer as it goes, hopefully we'll all be out of jobs and really, maybe surgery won't be needed in the next 1 to 2 decades or even earlier.
So, Lynn, what you're talking about is de-escalation, which we
Yes.
really have hallmarked across not only the surgical arena, but also the radiation arena, as well as the medical oncology, the systemic treatments that I discuss with
Yep.
patients. But it really comes down to what is the breast cancer or the precancerous lesion that has been found in someone's breast? What is the profile of that cancer? And I will tell you that if I have two patients the same age, the same height and weight, they were identified by mammography and ultrasound. They have no family history. They ultimately got the same surgical recommendation and axillary recommendations. They finished they were even married to the same man at different times. That's how identical they are on paper. Yet
Okay.
those two women are going to have very different outcomes because of where the breast cancer grew, what that
Yeah.
patient's makeup is all about, the differences in these breast cancer cells. If I see 60 patients in 1 week, I'm seeing 10 different breast cancers. Can you
Mhm.
speak to that a little bit?
So all breast cancers are not the same. When you go to your oncologist, surgeon, whoever you may see, first ask what type of cancer is this? Is this a ductal? Is this a lobular? Ask what that means. What we know and how we explain it to our colleagues is completely different from how we explain it to patients. Patients need to know the biology tumor of this, receptor statuses, what's the profile of my tumor, what's the grade of my tumor, how does this all fit in, what's my prognosis, what's the type of surgery, how is Dr. Theodulu going to recommend chemo for one patient and not chemo for the other, oncotype recurrence scores. When a patient comes in, it's kind of like a deer, with headlights. Just like it's just so much information, but it's our duty to explain it so they understand everything that we're trying to convey to them, to understand really what type of profile. Do you really need to do the oncotype score on this? Do I really need radiation? I think if anything the patient gets from our podcast is always question the doctor. Would you do this to your mother, your sister? Do I really need this? Are you over treating me? That's what I think is very important.
I think one of the most important things that we can say is yes, we may be over treating a patient. What we don't want is to undertreat a patient.
Sure.
And, we've all been on the other side of the desk, either personally or with family members or friends. That feeling of being a deer in headlights is certainly
Mhm.
so prominent. One of the I think most important things that you said, not that you're not saying important things across the board, but the thing that resonated with me is, you know, you discuss things with your colleagues, you discuss things with a patient, but your patient has to know. And I remember when I was in pre-med, I took physics with calculus, and I opened up the book and I started to cry. It was like a foreign language. I had no idea what I was looking at. And my professor came over to me and he said, "What's the matter?" He thought that something had happened in my family or personally. I said, I don't understand this book. And he said, "Maria, it is up to me to teach this in a language that you will
Mm.
understand." He
Yes.
said, "There's nothing that can't be discussed. There's nothing that
Mhm.
can't be taught. There's nothing that can't be understood as long as the conversation exists in the language that you understand." And I will tell you that I find that I speak different languages to different patients. I draw
Yes.
cartoons all the time. Um,
Mhm.
what is some of the issues that you confront in the clinic when you meet someone who's in that headlight? They are frozen, they're
Mhm.
terrified. All they can think about is, I'm going to die. I'm not going to see my daughter graduate. I won't be able
Mhm.
to raise my grandchildren. Or a young patient, will I be able to have children? They're so
Mhm.
terrified at that moment. How do you approach that patient? Because you're usually that first person that's
Mhm.
going to do something to that patient by way
Yep.
of surgery or a recommendation that's going to really change their life tomorrow compared to what it was yesterday.
I feel that we as doctors have a profound sense of duty to make our patients feel comfortable. They're only seeing us for a set amount of time, yet they trust their whole health with us. So when I have a patient come in, I have to figure out how I can communicate with them and if they have a loved one with them to understand what I'm saying. So if you have someone who comes in from rural Albany, 2 hours away, who hasn't seen a doctor for 10 years but felt a lump, you have to try to gain their trust and say, I'm going to take care of you. These are the things you need so they can understand what you're saying, as opposed to someone who's Googled for the last 24 hours. Tell me if it's luminal A, tell me if it's luminal B, what exactly is the radiation treatment? So you have to really listen to your patients to see if they're understanding what you're conveying. And I will say the majority of times I have patients who really everything kind of goes this way, and all they want to know is, when am I going to have surgery? Am I going to survive? Then you have a follow-up appointment. You could have a telephone visit or ask them to come again, because you don't want to take someone to surgery with them completely not ready for it. You just, there's a sense of trust and listening that you need. Not to pivot the conversation a little bit, but I will say the majority of my patients just come in saying, I have cancer, I want bilateral mastectomies, take care of me right away.
Mhm.
So that's another discussion where, with the research data and the literature and the guidelines by the American Society of Breast Surgeon guidelines, I have to say, this is the survival benefit from a mastectomy and lumpectomy. There's no difference if your genetics are negative. It's when you get their trust, they're willing to understand the data and the recommendations that you're given, even if they come in with a completely different set of things that they were planning to expect.
Sure, because most of those things that they're planning for or are thinking about in the waiting room before their name is called to see you are based on emotions, fear.
Yeah.
Understandably, not one of us would be in any different place. But I
Yes.
think at that point in time, to be able to start the conversation about the type of breast cancer that was
Mhm.
found, whether it's
Yep.
lazy breast cancer,
Mhm.
whether it's an aggressive breast cancer, whether it's a precancerous lesion. I can't tell
Yes.
you how often I see patients who have had in situ carcinoma, which is a
Mhm.
precancerous lesion, and they run around in all of their charts saying, I've had breast cancer.
Yes.
And it makes me sad that
Yes.
there's so many umbrellas that one can choose to live under and cast a shadow over them. I think
Yes.
much of our responsibility is to make sure that it's the right umbrella when
Mhm.
they have all the right information for that particular breast
Yes.
cancer, the behavior of that breast cancer, what we have seen over the past century of the
Mhm.
behavior of that breast cancer, what we have available to them. Then they can close that appropriate umbrella, keep it at their side as a steady reminder of what pathway they're taking. I can't
Correct.
imagine the difficulty that you confront when someone may not be prepared during that visit to hear this information
Yes.
and bringing them back a second time. I applaud you. That makes so much sense. It really should be a standard of care. I know that there was a study performed at Memorial Sloan Kettering Cancer Center over 35 years ago, and I'm really dating myself. And patients who were being taken to the surgical arena for mastectomies and lymph node interrogation. And back then, frozen was a big deal,
Yeah.
looking at pathology before the final pathology to get an idea.
Mhm.
Patients were told what was found, and then the psychiatrist who was leading this study, Mary Jane Massey, went back 24 hours later, and the patient didn't remember anything that the surgeon said.
Yeah.
Not a thing, not a thing,
Yeah.
and we have to be very sensitive to that. When a patient comes into you, Lynn, and
Mhm.
they are 30 years old, they have found a mass in their breast, and thankfully their gynecologist took the bull by the horn and said, let's get this evaluated. I can't tell you how
Mhm.
desperate it is when somebody is told, oh, you're too young for breast cancer,
Yeah.
come back in 6 months, and by then we have a full-blown aggressive disease. That 30-year-old comes to you, they felt a breast mass,
Mhm.
biopsy was performed, it's a cancer. How do you
Mhm.
approach that patient? This is a woman now,
So,
whole life is ahead of her. She's not even engaged.
so first of all, if she comes alone, I ask her, do you want to put someone on speakerphone or do you want to record the session? Because for anyone, any age, to deal with that is a tragedy, but especially someone who's younger, and if they have someone nearby with them, I ask them if they want to record it. And then I look at them and I said, I'm here to take care of you as family, and you're going to get through this. And then, as long as there's this trust, then I said, You can stop me at any point if this is overwhelming. And then I start slowly going into it. When, as a doctor, you talk, but you also have to look at your patient. Are they there? Should I take a break? It's like you said, Maria, with the study with the psychiatrist, seeing how the patients felt 24 hours later. A lot of them, it just it's just so much to deal with. So you actually have to make sure that they can absorb some of it. But the most important thing is, I'm going to take care of you. I'm going to treat you like your family. These are the next steps, and we will get you through it. And I'm going to connect you to an oncologist like Dr. Theodulu. We will be calling you. We will be making sure you have the appointment. We're going to follow up after you talk to her. And it's just important to just totally figure out if they're okay now to understand and go forward.
I think
So
the key word that you've been saying over and over again is that word trust.
mhm,
And I think that so much will settle someone
mhm,
who's on the other side of the
yes,
desk, or the one who's sitting on the examining room table, or someone
yes,
who's alone, or even with someone, because that significant other, that family
yes,
member, that friend becomes part of the patient.
mhm,
We're
yes,
taking care of a team and need to address their concerns who are sitting there
mhm,
with the patient, so they don't say something different that may
correct,
not be based on anything that's relevant. So we need to educate those family members, those significant people who are supporting the patient, that we're all on the same wavelength. And that word trust that you have repeated is, I think, the first segue to being able now to say, this is what we're going to do. This is where we're going. This is where we hope to be at the end of this journey. And it's a journey. As
yes,
you said, you refer your patients to all of the ancillary services that they may need or may not need, just they're familiar with things, so they're not surprised when they hear what you may recommend after the surgery. Talk to
mhm,
us a little bit about some of the wonderful de-escalation methods, and I love that word.
absolutely,
Really going from radical mastectomy in
mhm,
the early part of the 20th century
mhm,
to mastectomies with lymph node interrogation, and then breast conservation with sentinel lymph node biopsies.
yes.
Can you tell us a little bit about each step?
Okay, so standard surgery many, many decades ago was the radical mastectomy by Dr. Halsted. He's the founder from Johns Hopkins of surgery. Then from there, if you ever hear the word radical, as a surgeon, you should cringe. That's doing a mastectomy, lymph nodes, and removing the pectoralis muscle. That's a
So
no-no
you're
now.
basically left
So
with a
now the
skeleton and some
surgery is
spinal
often
cord.
offered.
Yeah.
Correct. Now what's offered is, do you need a lumpectomy or mastectomy and lymph nodes? So what happened before the pivotal Z11 trial by Dr. Giuliano Armando was one positive lymph node, a couple lymph nodes, you always get an axillary dissection. So just for the listeners out there, the axillary dissection is a surgery that removes the majority of lymph nodes in your armpit. The biggest risk of this surgery is up to 30% chance of lymphedema, permanent arm swelling. Can happen a couple months, can happen a couple years, can be quite debilitating. And two major nerves, if one of them is damaged, you can't shrug your shoulder. After Z11 came out, if you had one positive lymph node or two positive lymph nodes, that was that was not offered because they showed that the survival benefit and the axillary recurrence were similar in the two different groups. Now, the big trials that just came out, the Sound trial from Europe last year, and then they just talked about the INSEMA trial at the San Antonio Breast Conferences, maybe you don't even need a sentinel lymph node biopsy. So I mentioned axillary dissection, up to 30% chance of lymphedema, and a drain is placed. General anesthesia. Now, the other surgery is a sentinel lymph node biopsy. Usually, if you have a clinically negative armpit and you have an invasive cancer, a sentinel lymph node biopsy is offered. You check a couple lymph nodes, the first lymph nodes that would drain from the breast to the armpit. So you just take about 1 to 3 lymph nodes. Axillary dissection is usually eight, at least 8 or more lymph nodes. So taking just the couple lymph nodes decreases it down to up to like a 5% chance of lymphedema, so much smaller. Drain is not placed, and this can be done under MAC anesthesia, monitored anesthesia care. It's a colonoscopy sedation you get. Try to avoid a breathing tube, general anesthesia. It's more favorable with recovery. So that was usually standard for an invasive cancer. Take the cancer out, check a couple lymph nodes. These two pivotal trials, the Sound trial and the Insema trial, they're saying that if your tumor is favorable, less than 2 centimeters, ultrasound done in the armpit doesn't show anything abnormal, you don't even have to do a sentinel lymph node biopsy as long as you have radiation, which is pivotal. Some people think just doing the extra sentinel lymph node biopsy is not a big deal. Ask patients. After surgery, they'll complain more about any surgery done in the armpit. There's more nerves, there's more swelling. They complain about that site more than the breast. But now studies show that in certain favorable tumors, as long as you follow those recommendations, you might not even do that. And I say that this year and then last year I've been offering that, and that's what a lot of surgeons at accredited centers should offer. And if you give that data to patients in a way they understand, they're thrilled not to have to do that. Obviously, you have to ask as the patient, maybe I need it, maybe I don't. I always tell patients the number one thing you can do is question your doctor. Is this correct? Do I really need this? Do I not?
And I think the key is understanding your breast cancer. We keep going back to that. Uh, Obviously, if it's a lazy breast cancer, well differentiated, a
Yes,
small tumor, no bigger than 2 centimeters, which is
yes,
about an inch, and all of the MRIs, ultrasounds, whatever you've
mhm,
been doing for the patient, do not show anything suspicious in the axilla based on the age of the patient and what the profile of that cancer is. It's not just the
mhm,
size. If
yes,
it's, hormone receptor positive,
yes,
likes to feed on estrogens, but it's
yes,
negative for HER2/neu, as long as it's
yes,
not a triple negative, you
mhm,
look to see, okay, what is it that I was diagnosed with? And if it's favorable, if it's a fairly slow growing breast cancer, if it's not a patient who's 30
mhm.
years old,
Correct.
there are criteria that say, well, maybe we won't need that much
Mhm,
surgery, but that doesn't mean that you're not going to need radiation therapy. It does
yes,
not mean that you might not need to take something after
mhm,
the surgery to take care of total body, because once a breast cancer becomes invasive, in the best case scenario, there may be no cells that escape through the blood and
mhm,
lymphatic stream to some distant part of the body. In a moderate case scenario, there might be some cells that escape, but we use anti-estrogen therapy or other therapies based on
yes,
what the tumor's about. What we don't want is to have a patient move through their surgery, get their radiation therapy
mhm,
where appropriate, after we've defined what kind of breast cancer they have, non-invasive,
yes,
invasive, scary looking, not scary
yes,
looking, lymph nodes positive,
mhm,
negative, and then not take care of the rest of the body. And we'll have a whole
right,
other session about that.
mhm,
Lynn, when
yes,
when a patient comes to you and they have a family history that is
mhm,
just, mother was diagnosed with breast cancer, maternal aunt was diagnosed, her sister was
mhm,
diagnosed. I have patients who come in, their daughter was diagnosed.
yes,
You have a first degree and additional second degree family members, that sets up an alert. What
yes.
is it that you recommend when you meet a patient like that, regardless of their age?
They need genetic testing.
Mhm.
I will not do surgery or go forth with any surgical recommendations unless I get genetic testing
And
results.
what
So,
is genetic testing for those people out there listening to us that are just, being educated today?
genetic testing is a test, either saliva or a blood draw, and it tests a panel of genes. Usually, they test a slew of moderate risk genes and the high risk genes like BRCA. You get that test done, the results can come back in around 2 weeks or so, and it says, are you a carrier of a gene that puts you at moderate or high risk of breast cancer? The reason in patients like this where a huge alert button came off is, oh, I have a strong suspicion that she might carry a gene that caused her breast cancer. So if you come with a breast cancer diagnosis, and I'm I'm like, oh my goodness, this woman needs genetic testing right away. I wait for those results because that can affect the surgical treatment I offer the patient.
Mhm.
Also, I we get a slew of high risk patients, so patients who are not diagnosed with breast cancer but come in with this family history. They will absolutely be recommended those results. That is important for the patient, that is important for their family.
Mhm.
So the more you know about your health, the more empowered you are to make the right decision.
And it really isn't empowerment. It is a situation where you now are in control of part of your destiny. I've heard
Mhm.
from patients, I don't want to have genetic testing done. I don't want to know. And I spend a lot of time with those patients and I say to them, oh my goodness, wouldn't you be in a much better place if we can find
Yeah.
something that might be developing in a suspected high risk organ when it is curable? When it can
Yes.
be popped out and that's the end of it. So
Yes.
genetics are important. There's a difference between hereditary genetics, what you've inherited from a
Mhm.
family member, a mother or a father. Fathers also, I hear
Mhm.
that, oh, well, there was breast
Yeah.
cancer in my dad's family, but that
Mhm.
doesn't count. That's not true.
Not true.
Um, what about the genetics of the tumor itself, which is separate from hereditary genetics? You brought up earlier oncotype.
Yes. So, what usually happens is after you have surgery for a hormone positive breast cancer, pathology comes back about 2 weeks later. Then there's a conversation at our multidisciplinary conference. Should this patient get genetic testing on their tumor? What we call it most commonly is oncotype, 21 genes tested on the tumor. The way I explain to the patients is after your pathology comes back for an early stage breast cancer, to figure out how risky your tumor is, we often will order an oncotype. So the oncotype tests 21 genes on the tumor, and I tell the patients 3 to 4 weeks later, a number comes back. Higher the number, the more risky the tumor, and you will likely be recommended chemotherapy. If the number is low, that's just means it's less risky and it gives us confirmation that you probably don't need chemo. I explain it exactly like this so they and their loved ones can understand what's being recommended, what type of testing is ordered. And often a question I get is, wait, aren't you just doing genetic testing on me? Why do you have to figure out the genetic testing on the tumor? So even though there's genetics involved, it's a different type of testing and different type of result.
So, Lynn, to speak to what you've just said, those hormone receptor positive breast cancers that are invasive, um, those patients will more than not, after they've completed their local control surgery, go on a regimen of an anti-estrogen. If they're young, possibly tamoxifen. They're postmenopausal, an aromatase inhibitor. These are all ways of stopping any excessive estrogen that women make, regardless of their age, regardless of whether they're still having periods or not. That might feed a rogue cell that's hiding in the bones, the liver, the lungs. And we need to know if that patient is at a higher risk for these tumor cells not responding appropriately to anti-estrogen therapy, and maybe chemotherapy will be needed. The reason why this all developed was to avoid chemotherapy in many patients who really don't need it. I'm of the era, and again, I'm dating myself, where we gave everyone chemotherapy if their tumor was a centimeter or larger, regardless of the lymph nodes. So,
Yes.
having something like Oncotype say that two-thirds of the patients that I see do not need
Yes.
chemotherapy, I celebrate with them. Because when we're talking about a recurrence, what we're worried about is always a local recurrence. That's why
Mhm.
Dr. Choi will continue to get mammograms and ultrasounds and MRIs where needed on her patients, even after they've had their surgery. But I worry about something coming back outside of the breast and the lymph nodes. So getting an
Yes.
oncotype or a test like it is really important.
Mhm.
Lynn, when does a patient see a plastic surgeon?
So I so with anytime I offer mastectomies to patients, I always say, "Are you interested in reconstruction?" And some of the most of the time people are like yes or no, and patients who hesitate, I say you're seeing a plastic surgeon. I always tell patients the more education you have, the better decision you can make. So anytime a mastectomy is offered, I always offer them to see a plastic surgeon. However, some patients, when I recommend a mastectomy and they just really they just can't, they'd rather not do treatment than do a mastectomy, then I also talk about seeing a plastic surgeon. Maybe you can have a big lumpectomy and you can have a procedure by the plastic surgeon, oncoplastics, rearranging the tissue so the big defect will not appear as a big defect. So I always offer it anytime I think reconstruction is there or patients ask for it. So I just want patients to be the most educated they can before a final surgical decision can be made.
Right. And some patients will have a mastectomy recommended because that's the only appropriate surgical control that should be done based on the size of the tumor, how dispersed it is, what the features of the tumor are. And sometimes it's patient request, but breast conservation is available, and those outcomes, as Dr. Choi said, are similar to a mastectomy if radiation therapy is given. And now we know that in some small subsets of patients,
Mhm.
based on their age, the type of breast cancer, they can even get a lumpectomy, and some of them who are over a certain mature age may not even need radiation. But those options are part of a educational forum to allow patient to help make the decision
Yes.
for their best well care. And if a deleterious genetic mutation is found that
Mhm.
is carried in the family, then that patient can have a very lengthy conversation with Dr. Choi regarding whether she wants to have bilateral mastectomies,
Yes.
because her risk is much higher of
Yep.
uh, having a breast cancer repeat itself over the ensuing years than the general population. Lynn, can you speak to that a little bit?
So when a patient, you're asking about the genetic mutation.
Yes.
Yes. So if a patient comes to me with a known genetic mutation, the recommendation with a high risk gene, a BRCA gene, is bilateral mastectomies. So I give them that option and I also talk to them about reconstruction. So if we want to talk more about reconstruction, I say this would be most likely a joint case. I'm going to send you to a plastic surgeon so they can give you two different options if you're interested in reconstruction. One option is implant based, which is um, it can be performed the same day, and usually patients can actually leave the same day or be discharged home the next day. So it's implant based. So the breast surgeon does their surgery, and then the plastic surgeon will go on to do the implant based surgery. The other surgery is called autologous reconstruction. So I tell patients so they can understand it, it's like doing a tummy tuck, and the the tissue that is removed is then inserted into the mastectomy cavity. So the first type of reconstruction was using implants. This is if you don't want to use implants or maybe want to use your own tissue, that tissue can be placed in the mastectomy cavity. I do tell patients that there is a big difference in length of surgery. So the implant based mastectomies bilateral usually take like maybe 2 hours with implants, another 1 to 2 hours. Same day discharge, possibly the next day. Autologous reconstruction using your own tissue from the tummy tuck. That is at least a 6 to 12-hour surgery. And the reason why that takes so long is for the tissue that you place, for it to survive, the connection is small microvessels are attached together. You stay at least a couple days in the hospital. And so that is the difference. I do try to explain a little bit, and I do so they have some sort of understanding before they see the plastic surgeon.
And certainly the length of rehabilitation and healing and their lifestyle is very different based on implant reconstruction
Yes,
versus tissue reconstruction.
yes,
This is so helpful and so meaningful. I think that if we walk away from this session, the important issue is that there are multiple different types of breast cancers in multiple different hosts with
mhm,
multiple different options. And those options are to ensure the best possible disease free survival and
yes,
overall survival for the patient.
mhm,
And please make sure that when you meet your surgeon, when you meet your medical oncologist, when you meet your radiation oncologist, that you're comfortable with that person.
yes.
There's not just one person out there. I know, Lynn, that everybody loves you. And so I'm thrilled to have you join me today on this chapter of breast cancer and surgery. Perhaps we can have another session down the line about precancerous lesions, the host of the different precancerous lesions or lesions found in the breast that may make a patient high risk for developing a breast cancer, how you approach them, and how I approach them. So I will ask the audience to listen in for part two of this. Lynn, thank you for your time. I know you have a lot of patients waiting outside to see you today.
I'm
And
happy to talk to you, Maria. You're who wouldn't want to talk to Dr. Theodulu?
I don't think there's a week that goes by that we don't speak 2 to 3 times on the phone. But again, thank you to Stacy and Richard Rosenthal for the grant allowing us to have these podcasts that will be available to everyone. And until next time, uh, bye, everyone. Be safe.
Thank you.
Bye.
Love you, Maria.
Love you, Lynn.
Okay.
Bye now.